Hello, I'm Nicholas Shearer, and in this video I will be discussing how shoulder dystocia can be managed by paramedics in the pre-hospital setting. Firstly, I will discuss what is shoulder dystocia, the risks, and how to identify it. This will be followed by a demonstration how to manage shoulder dystocia in the pre-hospital setting and discuss on potential complications. Shoulder dystocia occurs when the anterior shoulder of the fetus has impacted on the back of the symphysis pubis, halting spontaneous delivery and requiring specific maneuvers to continue the delivery of the shoulders, with the torso and limbs to follow. There are several risk factors associated with shoulder dystocia. Identifying these prior to labour can help a clinician to anticipate and prepare for such a potentially serious complication. When identifying shoulder dystocia, diagnosis can only be made once the head is born and spontaneous birth has halted. Key signs to look for are turtle sign and failing to birth the anterior shoulder. Additional warning signs include a prolonged second labour, head bobbing during contractions, and failure of the fetal head to restitute. In this demonstration, we are proceeding through the second stage of labour and the delivery of the head. Here we can identify two warning signs: head bobbing and a prolonged second stage. The head has been delivered, however, spontaneous birth has halted. Turtle sign can be seen as the head retracts against the perineum back into the vagina and the anterior shoulder has failed to spontaneously follow through with downwards traction. After shoulder dystocia has been diagnosed, timely management is required to reduce prolonging labour, which can lead to fetal hypoxia and other complications. It is important to firstly call for help, evaluate the situation and make a plan. Even with successful delivery of the shoulders after applying a manoeuvre, you may have an unwell mother and baby, both requiring medical intervention. Begin with the McRoberts manoeuvre. If unsuccessful, attempt the Rubens 1 manoeuvre, followed by rocking Rubens, and then all fours manoeuvre. Prepare for urgent transport in the likelihood of failing to deliver after all attempts or rise of following complications. Remember, attempt each manoeuvre for 30 seconds. If unsuccessful, then move on to the next one. Further delay can result in greater fetal hypoxia. Be prepared. Have all necessary equipment ready. This includes PPE as well as medical equipment which may be later acquired if further fetal and/or maternal complications occur. The McRoberts manoeuvre. The objective is to increase the pelvic diameter, release and deliver the anterior shoulder, followed by the posterior shoulder. Place the mother at the end of the stretcher or bed. Assist her in flexing her knees towards her chest, also known as knees to nipples. Apply downwards traction and encourage the mother to push. Attempt the McRoberts manoeuvre for 30 seconds. Approaching the 30-second mark, prepare to move on to the Rubens 1 if unsuccessful. Let's move on. The Rubens 1 manoeuvre and rocking Rubens. Rubens 1 and rocking Rubens involve applying suprapubic pressure to reduce the diameter of the fetal shoulders, releasing it from the symphysis pubis and aiding delivery. To apply the Rubens 1 manoeuvre, the mother remains in the McRoberts position. Further paramedic assistance will be required. Externally locate the symphysis pubis. Above this, you should find the impacted anterior fetal shoulder and apply suprapubic pressure to the posterior aspect of the shoulder for 30 seconds in a downwards lateral motion towards the fetal chest. Whilst applying suprapubic pressure, have your assistant apply gentle downwards traction to the baby's head. If unsuccessful after 30 seconds, move on to the rocking Rubens. The rocking Rubens involves applying intermittent pressure using compressions over the same area for another 30 seconds, whilst your assistant continues to apply downwards traction to the baby's head. Warning: Do not apply suprapubic pressure during contractions, as this may result in uterine injury, rupture, and further serious complications. Unsuccessful after 30 seconds, move on to the all fours maneuver. Whilst attempting the next maneuver, all fours, begin preparing for the next stage and have one of your assistants prepare for extrication and urgent transport. The all fours maneuver, also known as the Gaskins maneuver or reverse McRoberts. The mother is positioned on her hands and knees with her hips flexed, buttocks elevated, and head lowered to the ground. This aims to increase the pelvic diameter and deliver the posterior shoulder first, followed by the anterior shoulder. The paramedic applies gentle downwards traction to the baby's head to deliver the posterior shoulder first. Encourage the mother to push. Warning: whilst repositioning the mother into the all fours position, rotation or flexion of the hips may result in a sudden release of the impacted shoulder and delivery of the fetus may resume. Be prepared in case this occurs. Success! We have delivered the baby. Congratulations. Cutting the umbilical cord. Wait for the cord to stop pulsating. Place the first clamp 5 cm from the baby's abdomen. Milk the cord towards the baby. Place the second clamp 2 cm away from the baby's abdomen. Cut between the first and second clamps. Apply the third clamp to the cord near the perineum. The third clamp will be used to assess for cord lengthening, which will indicate placenta separation and the progression into placenta delivery during the third stage of labour. If these manoeuvres fail to resume delivery, transport under lights and sirens to the nearest ED with obstetric services, providing pre-arrival information, and continue to apply suprapubic pressure with the patient in the McRoberts position, alternating between Rubens 1 and rocking Rubens every 30 seconds. Also, insert 2 large bore intravenous cannulas in case IV medication or fluid resuscitation is later required. Emergency consultation with a physician may be considered if available en route for further instructions and additional maneuvers. There are various complications following a shoulder dystocia. One of the main concerns for paramedics is neonatal respiratory arrest or cardiac arrest, and if identified post-birth, requires immediate intervention and resuscitation efforts. Additional complications include brachial plexus injury, asphyxial injury, traumatic injury, central nervous system damage, and long bone fracture. Major maternal complications which may require paramedic intervention include postpartum hemorrhage and uterine rupture. Additional complications include perineal or vaginal laceration, traumatic bladder injury, rectovaginal fistula, and psychological trauma. Let's do a quick recap. Key signs to identify and diagnose shoulder dystocia are the turtle sign and failure to deliver the fetal shoulders with normal gentle downwards traction, and specific maneuvers will be required to allow delivery to resume. Recapping management. Remember to call for urgent assistance. You cannot do this on your own, and additional resources will be required. Evaluate the situation and make a plan. Begin with attempting the McRoberts maneuver. If this is unsuccessful, then attempt the Rubens 1. If you are still unsuccessful, move on to the rocking Rubens, then the all fours maneuver if the rocking Rubens fail. If all maneuvers fail or further complications develop after delivery, proceed with urgent transport and continue care en route.